So I believe that the current healthcare system can't be reformed.
Okay.
I just don't. I think we've tried. We've chipped away at it. We've done some good work. I think what I realized the last year or two is that we've already built a new one. The issue is we have to make sure that it maintains its integrity. And it's been built by people who are transparent and who believe in good ethical standing. And so my worldview is that if we can connect as many employers as possible with these advisors who are verifiably transparent, we'll do good work. It'll figure itself out as we continue to build it. And because these are the advisors that are building it and working in it. So the goal really is to continue to grow this network of advisors who are verified so that we can succinctly say to an employer, Spencer is one of the good guys and we recommend that you work with him.
Yeah.
And then we know that Spencer is getting access to all of those tools and resources that will help them exist in this parallel healthcare system and have better outcomes and spend less money.
It's one thing to say he or she is one of the good guys or gals,
right?
But then give them the tools available so that they are actually doing what they espouse that they're going to do, right? That is where you get that network effect because the outcomes start to build upon themselves, the referrals. It reinforces probably to the consultant, I assume, as well, that I am doing good work.
Yeah.
I should continue to pour into this and get better. And, I could see where that would have like sort of a compounding effect, but why, if you don't use the word reform our healthcare system, what do you think it needs to be instead? Because you've got this parallel thing you've built, but what should happen? Is it an implosion? What should we do with it then, in your mind?
So the first symposium I hosted at the very end, as I was saying farewell to everyone, I said, I want everyone to go away and think about it, and I want all of you to envision that we blow up the current system, and it's in pieces all around you. I want to know what pieces would you keep, what pieces would you throw away, what would you bring in from outside, and I want you to email me what you think those answers are. And I think I got 2, maybe 3 emails. Nobody really knew. Everyone had kind of. We were talking about it at the symposium. Everyone had kind of an idea. Here's what I think. And Jeff Gold, do you know Dr. Jeff Gold?
Yeah, I think did I reference him earlier on the DPC talk?
Yeah.
I don't think I mentioned him by name. Yeah.
He is the grouchiest direct primary care physician, but he's probably one of the most insightful. And he embarrassed me on a call a few years ago. I was having a coffee break phone call, and we were discussing just the potential of universal healthcare. Would it work in the U.S.?
Okay.
And we had someone on from Canada, someone from England, and someone from New Zealand discussing it. And he sat very quietly and he watched the whole call. And at the end, he raised his hand, and you never know what's going to come out of Jeff's mouth. So I was like, okay, hi, Jeff. And he said, Emma, I just don't know how you have the audacity to have this whole discussion about universal healthcare without asking a single clinician what they think. And while I was embarrassed, I also couldn't argue with him at all. I thought, gosh, why don't I ask doctors what they think? And so I started doing that. A few years ago, I started asking doctors. And for me, it's clear that the only thing that will fix healthcare is restoring the doctor-patient relationship without anybody in between it. So that's what we work on. And right now it's DPC. I think there's room for that to evolve.
Yeah.
I wish that we could create an inclusive healthcare system that was free of insurance completely. I think the DPC model would actually work well for things above and beyond DPC, the membership model. I think there's some work to do there, but that's kind of where I'm going with it.
Well, don't let me forget, I want to come back to what are some of the other pieces that are brought up, but I do want to continue down this line of discussion with DPC. What else would you do? How would you level up DPC to be able to handle more comprehensive style interventions than not just your typical primary care?
So I think it already exists. It's just about putting the pieces together, which is, I think, what I'm kind of doing in a way. But if you think about it, we have direct primary care right now that takes care of the primary care stuff. Everybody knows Green Imaging, Dr. Kristen Dickerson. She can refer you for your imaging that you need. We know that most labs can be done in DPC offices or independent labs that are cash pay or membership fee. And then right here in your backyard, you have North Texas Team Care, Dr. K, who runs his clinic, his surgical center on a very similar model. And in my head, I'm like, why don't we just connect all these pieces? And if we connected all these pieces and we figured out what does that really cost monthly? And could we do a sliding scale for folks in lower income areas? we could literally create an entire healthcare delivery system, a clinic, a hospital that never has to file a single piece of insurance. So then the question is, okay, how do we replicate that in the same place so that you can have all the pieces together?
When I even ask the question on top of that is, what do you retain from the existing system, right? If there are pieces that were scattered about and you would pick them up, you ask that question, what were the pieces that do seem viable to continue to use?
The people.
Okay.
Yeah, that's,
Okay.
I mean, some of the technology. I will give Kaiser is a good example, right? They lean to the good side, but they have state-of-the-art hospital systems. They leverage technology in their surgeries. Now we see everything being done laparoscopically, but we also forget that that takes an incredibly skilled surgeon to operate on someone laparoscopically. In fact, it takes a lot more skill to do that than operate on someone openly. So I think we keep all the people, we keep the clinicians, and then we restore their relationship with patients, which is what they all went to school to do in the first
So is
place.
the problem really the insurance then?
Yeah.
Okay, so then what do we retain insurance to do? Because like David was talking about in his episode, and I would be in agreement with him, that insurance in its original form, or what it was supposed to do, is a catastrophic style situation. That's why you purchase insurance, for something that is totally unforeseen, an extreme amount of money, and is there to protect you in that type of event. Your home burns down as an example. Total your car as an example. So how do we apply that to healthcare and restore it for the way that it was supposed to be used?
I think your question has a multifaceted answer, but something that you would understand, think about aggregate stop loss. Is it expensive?
No.
But is it effective if you need to use it?
Yes.
Right.
Yeah.
So it's not all that different, right? If we're pooling the risk as we do in stop loss and captives, which is a great strategy for some people, I view it kind of as the ag insurance that you hope you'll never need. It's cheap, it's affordable, but it's for when it goes real badly, right? I think you can deploy something really similar to that in the healthcare system, as long as people are getting the crucial primary care that they need. That includes mental health resources. And anything up to the specialist level should be completely affordable. And then we use something like aggregate insurance or that model or replicate that model to make sure that we're protecting everybody above that.
So does the employer in your mind, at least if we're talking about an employer-employee relationship in that type of healthcare or health insurance delivery, I want to make sure I partition that. Do they still play a role, and are they still the payer in that situation then? If we get rid of insurance?
Gosh, that's a good question.
I mean, I'm asking questions I don't know the answer to either, but I love sort of the thought experiment of this, because I've often thought, what if you took the notion of stop loss insurance at an employer level? If I, as an individual, could buy stop loss insurance, but then simply healthcare itself was paid for in some sort of cash-based or direct contracted model, but I'm still not the payer. Ultimately, the employer is still able to give me health insurance or coverage, right? So how do we achieve that?
Well, what's interesting is you think about really small groups. So I used to not help small groups, honestly, because I had no idea how to help them. I grew up in large national account self-funded. I had no idea really about small group coverage. But we had a lot of small groups come and just say, is there like anything you can do to help? And so we started doing direct primary care with medical cost sharing. Kind of the same premise, right? Because the employers are paying for that. They're paying for the DPC membership for all of their employees. And then they're also subsidizing some kind of medical cost sharing. So when that catastrophic thing happens, they're able to share in the cost or help in the cost. I think you're right. I think it kind of looks a little bit like stop loss insurance. And it is something that the employer can use for recruitment and retention just as well. But it would cost the employer a whole lot less, and it wouldn't cost the employee much.
Yeah.